Welcome everyone to our second Medical Student Journal Club put on by the NANS Resident Fellow Section and Young Neuromodulators. Let's go to the next slide. So tonight we'll have two medical students who will be presenting on articles about neuromodulation and cancer and pain. And following that, we'll have a Q&A session with a very special guest moderator tonight who we will introduce in a little bit. But first, we're going to talk about some ground rules.
All righty, thank you again for joining this evening. So just to go over a few ground rules for the webinar. So if you have a question, feel free to type the question to the question panel section. We'll filter out the questions as they come through, and we'll try to get through as many as we can towards the end of the webinar. And again, please, as the audience, just make sure you're on mute throughout the webinar. And for anyone that's not able to attend, we'll make sure we record it, and it'll be on the NANS YouTube channel within about 48 hours. Next slide.
Yeah, well, good evening, everyone. I'd like to introduce myself. My name is Edward Pingenot. I'm a fourth-year medical student at Kansas City University. Really appreciate you for coming. For everyone who was involved in putting this together, for the moderators for being here. Thank you, Dr. Galati. I'm looking forward to hearing from you. Excited to be here.
Hi, everyone. My name is Pankti Acharya. I'm a fourth year from Rowan SOM. Just want to thank everyone for having me today. Very excited.
Hi, everyone. I'm Cece. I'm one of the officers as part of the NANS Resident Fellow Section. I am in my last year of anesthesia residency and an incoming fellow at Stanford.
Hi, everyone. I'm Ankur Patel, and I'm also one of the officers for the NANS RFS Young Neuromodulator Committee. And I'm one of the pain medicine fellows at the Weill Cornell Tri-Institutional Pain Medicine Fellowship Program. I'm really excited to be here today so we can kind of talk about cancer pain. I want to take a couple minutes and introduce our guest speaker and moderator today. So we're very excited to have a talk which will be moderated by Dr. Amit Gulati. He's actually one of the authors of one of the articles that we'll be presenting tonight. Dr. Gulati is the director of chronic pain, specializing in interventional cancer pain management at Memorial Sloan Kettering Cancer Center. He's also the program director at the Weill Cornell Tri-Institutional Pain Medicine Fellowship Program. And he's really highly involved in training education and gives lectures and teaches at workshops and topics about ultrasound-guided pain procedures, sympathetic blocks, and cancer pain management and neuromodulation. So we're really excited to have Dr. Gulati tonight. Thank you, Dr. Gulati, for joining us.
Yeah, it's wonderful to be here. It's always great to train our young minds. I was a medical student. I discovered pain management way back in I guess it was 2001 timeframe. And so I had the fortune of some of our I was actually an MS3 when I wanted to become a pain doctor. So to see you guys all young and excited, hopefully we can get you to the right path to really move this field along. There's been a lot of innovation in the last, I guess now 20 years since I've been sort of a medical student and beyond. So there's a lot of opportunities for improvement. Neuromodulation has really come a long way from both a technical and a clinical standpoint. So a lot of novel ideas coming that you get to be a part of. So pleasure to be here. I'll let you guys start with the presentations, and I'm happy to chime in as needed.
Excellent. Well, we'll jump right in. We have some objectives for this evening. First, we want to provide a broad overview of neuromodulation therapy for cancer pain. We want to do that by highlighting two articles, the first one being a narrative review and the second one being an observational study. So let's begin by discussing a narrative review by Howe et al. Entitled Interventional Therapies for Pain in Cancer Patients. Believe it or not, as Dr. Patel mentioned, this article was chosen before we knew that Dr. Gulati would be with us this evening. So again, we're honored and excited to have him here tonight and look forward to his commentary. It is well known that pain is profoundly impactful and prevalent in the lives of patients with cancer. In a 2016 systematic review and meta-analysis, 66% of patients with advanced metastatic or terminal disease reported having pain. And also the study showed significant pain pervasiveness during and even after curative treatment. In addition, moderate to severe pain, defined as a numerical rating score greater than 5, was reported in 38% of all patients with cancer. And as one might imagine, pain, especially when untreated, can have a wide-ranging effects on quality of life, functional status, and psychological well-being. And due to the multifaceted contributors to cancer-related pain that span the mind-body spectrum, it requires an equally broad therapeutic approach that might include some of the interventions that we'll discuss in the next 20 minutes or so. So some of you might be familiar with the stepwise algorithm developed to address undertreated cancer pain, known as the WHO analgesic ladder. A brief overview or review for us all. For the first step, for mild pain, conservative treatment involves non-opioid analgesics. For moderate pain, weak opioids. For severe pain, stronger opioids. And interestingly, originally the ladder had 3 steps. Now that ladder has been modified and includes a 4th step, recognizing interventional options as a core component of cancer pain management. And so we'll explore some of these interventional therapies a bit more now. And I'll hand things over to my colleague.
This article discussed several interventional therapies that can be used for MSK pain. The first being trigger point injections. So this is basically when a region of muscle is causing myofascial pain. And basically this intervention involves dry needling the affected muscle to decrease inflammation and break up any sort of muscle fibers. And this would then help with the pain. Next up is joint injections. So this involves injecting steroids or local anesthetic into joint spaces using anatomic landmarks, ultrasound, and fluoroscopy. There was actually a study done by Few et al. That outlined improvement using bilateral steroid injections for palliative pain and found it to be an effective management. Next up is medial branch blocks and radio frequency ablation. This usually targets the medial branch blocks that innervate the facet joints, and it's a popular option for cancer pain relief. Epidural steroid injections is basically when you inject steroids into the epidural space to decrease inflammation, and this is typically used for radicular pain. And then there are SI joint injections, and this is basically identified for patients who have pain with specific movements. And then vertebral augmentation is usually for cancer patients who have some sort of compression fracture. And this is when you inject cement into a vertebral body to stabilize that region. And the article also talked about several different other interventional therapies for visceral cancer pain. The first being a stellate ganglion block. So as you can see on the picture here, this usually targets the upper body, and it's used for CRPS as well. There's also the celiac plexus block and neurolysis. This is usually used for abdominal pain. There's also the ganglion impart block, which is usually used for coccydynia, and the lumbar sympathetic block, which usually targets the psoas muscles and retroperitoneum. And then there's also the superior hypogastric plexus block, which is usually used for the lower abdomen and pelvic area. And this is just like a better picture that just kind of goes through the stellate ganglion block. So you can kind of see here where the point of injection would be, and kind of like identifying the different landmarks. And this is a better overview of the celiac plexus block. So you can see here, this is usually where the needle would go, and these are the different landmarks that would be around it. And like I said earlier, it's usually like in the abdominal area. And this is the ganglion impart block. As you can see here, you can see like the nerve bundle, and usually it is used for coccydynia. And then this is the lumbar sympathetic block. There's several indications. However, this is very common for cancer patients. And then this is the superior hypogastric plexus block. So this is usually where the needle would be inserted, as you can see here, indicated by the yellow. And then the vessels are also outlined here, so it's kind of just important to know your landmarks and know, like, using ultrasound, like where you're going.
So let's talk about neuromodulation. Neuromodulation is an umbrella term that involves a couple therapies that we'll be talking about this evening. Intrathecal drug delivery systems, or IDDS, Generally involves a catheter implanted into the intrathecal space to allow opioids or adjunctive medications to infiltrate directly into the central nervous system. The catheter connected to a continuous external fusion pump that is surgically embedded oftentimes into the abdominal wall. And a medication reservoir located within the pump is easily accessed percutaneously with a needle through a port for refills and other programming. In spinal cord or dorsal root ganglion stimulation, electrodes are placed using fluoroscopic guidance into the epidural space to overlie either the dorsal columns in traditional spinal cord stimulation or the dorsal root ganglion in DRG stimulation. An impulse generator connected to the electrodes is also inserted percutaneously and can be programmed by an external device. And although it wasn't included in the article, thought I might mention peripheral nerve stimulation as another viable intervention that is being increasingly used for patients with focal neuropathic pain. And so we'll go into some of these therapies now individually. Intrathecal, well, what does that mean? Let's start there. Intrathecal describes the fluid-filled space between the thin layers of tissue that cover the brain and the spinal cord. IDDS delivers medication directly into the spinal fluid from a pump, again, often implanted under the abdominal skin, and there's a picture of that. The medication in the pump, depending on what medication is used and the severity of pain and frequency of use and so on, can last 2 to 3 months or so and can be refilled easily in the pain clinic through a small needle. There are 3 approved medications that can be used in the pump: baclofen, often used for spasticity management, and an opioid, morphine, and a non-opioid ziconotide, also known as Prialt. Dr. Galati can speak to this a lot better than I can, but it is noteworthy to say that other medications are sometimes used in the pump as well, with different combinations. Some of those include clonidine, bupivacaine, ketamine, and ketorolac. So what are the advantages of using IDDS? Well, there are many. First, because of where the medication is being distributed, the medication can easily cross the blood-brain barrier. Also, lower doses of medication are required compared to oral systemic agents. In fact, it would take about 300 milligrams of IV morphine to offer the pain relief of just 1 milligram of intrathecal morphine. This allows for similar or even better pain relief in some instances with less symptoms like nausea, constipation, and sedation. It's also user-friendly for most and can be used in a variety of pain conditions. There was a large prospective study done, which we'll actually discuss soon in our second article presentation, that was conducted with about 1,400 cancer patients and showed significant improvement in pain scores registered at 6 and 12-month time points. That study was corroborated, or the findings were corroborated, by a 2017 study showing greater than 50% pain reduction by about 86.4% of patients at discharge, 79.5% at 1 month, and 63.6% at 3 months. Some contraindications that are noteworthy include coagulopathy, local or systemic infection, or aberrant anatomy. And adverse effects are often related to medications that are used in the pump, can also include the procedure itself. For those adverse effects related to medications, for morphine, we want to look out for respiratory depression, would be the big one, catheter tip granuloma, and medication dependence, as it is an opioid. With a non-opioid ziconotide or Prialt, adverse effects that have been reported include cognitive effects, psychiatric effects, nausea, nystagmus, and confusion. There was a study done in 2007 in 55 opioid-tolerant patients with advanced cancer that showed early and late complications. You can see them here on the slide. But noteworthy, or especially good to take note of, is a reoperation for bleeding or a change in catheter position, otherwise known as migration, catheter migration. For late complications, of course, infection or discontinuation of therapy have occurred. So now we'll jump into spinal cord stimulation as a broad term for cancer pain, which tonight we'll talk about traditional spinal cord stimulation and dorsal root ganglion stimulation. And we'll look at the mechanisms just briefly. So for SCS, it is believed that SCS utilizes the gate control theory by introducing external neuromodulation in the form of non-painful electrical signals from percutaneous electrodes placed over the dorsal columns. So this cause essentially activates alpha beta fiber activation, causing inhibitory neuron activation and ultimately the inhibition of nociceptive neurons in dorsal columns. The mechanisms for DRG, or those that have been proposed for DRG, are many, so we won't go through all of them now, but we'll just say, and perhaps Dr. Colati can comment on this, that mechanism is similar to SCS, though the placement of the leads is obviously in a different place over the dorsal root ganglion, which involves maybe a different combination of fibers, and is thought to offer more targeted therapy. Per the literature, the role of spinal cord stimulation in refractory cancer related to pain is unclear, but I thought this was interesting. The first two spinal cord stimulators implanted were in patients diagnosed with bronchogenic and pelvic carcinoma. And you can see here some additional indications. Want to hit home that these stimulators are especially helpful with neuropathic pain, and you can find, or you might see, neuropathic pain involved in a number of cancer pathology and syndromes, and there are some listed here. Also, when iatrogenic complications arise, including radiation-induced peripheral neuropathy, spinal cord stimulation might be a viable option. And the contraindications here for traditional spinal cord stimulation is relative if they have an existing pacemaker or defibrillator, absolute if there's coagulopathy, active infections, or aberrant anatomy, much like the intrathecal therapy. Some complications that may occur are CSF leak, infection, but electrode migration, again, is one that we want to really emphasize here, in addition to the possibility of a device failure and other things. So dorsal root ganglion stimulation, the large-scale studies investigating efficacy in this population are limited, but there was a 2015 retrospective study looking at pulsed radiofrequency DRG stimulation, in 15 patients with intractable pain from metastatic vertebral lesions. And almost all experienced significant pain relief at rest and with ambulation at 3 weeks. So that's great. Now, contraindications are similar to SCS, and the adverse effects are as well, again, emphasizing lead migration as a potential adverse effect or complication. So some key points. Patients with cancer often experience pain at one or more points along the spectrum of diagnosis, treatment, and survivorship. And chronic pain in cancer patients continues to be undertreated. And there are interventional pain techniques that we've discussed that are now being recognized as a core component of the WHO analgesic ladder. These techniques may offer effective analgesia with less systemic toxicity and dependency than traditional first or second line oral agents. And these interventional approaches should be evaluated as an early option and central component of a multidisciplinary approach to treating pain in cancer patients. That concludes that article, but I'll take a brief pause. Dr. Galati, do you have anything that you'd like to mention, or would you like for us to continue moving forward?
Well, you pretty much described the entire field of interventional cancer pain management in about 20 minutes. I think maybe I'll be a little bit briefer and just kind of give some highlights of where things have come from and where things are going for cancer pain management specifically. When we started in 2001, at least when I started as a physician attending at 2007, at that time, intrathecal drug delivery or giving medications in the spinal space was kind of the way to treat really complex malignant related pain that's focal in nature, like extremity, chest wall, abdomen. And some of these other ideas of chronic pain management hadn't really made it through to cancer pain for a couple of reasons. Number one, in the 80s and 90s, when people are suffering from cancer, they're reaching their end of life. So they're using opioid management as their primary source of pain treatments. And a lot of our colleagues at various institutions, MD Anderson, for example, introduced concepts of kind of like not only taking care of the patient, but taking care of the family, There's like psychosocial part of the pain management strategies for a cancer patient as it goes through their journey. Then we have some ideas of multimodal strategies, adding adjuvant medications. And the reason I'm bringing all this up is while we think about interventional cancer pain management and neuromodulation, in reality, for majority of cancer patients, they're being managed by pharmacotherapies. We come in when those things are not as effective, or what's really revolutionized cancer patients' trajectory is really the new treatments they have in the last 10 to 15 years and keeping them alive. So whereas you weren't worried about opioid tolerance and opioid other related issues, now you are, like a chronic pain patient. So now these interventions become much more important during the cancer patient's journey. We're getting better delivering cancer, focal radiation, focal therapies, specific therapies to certain cancer types. So as a result, you're seeing us having to pivot, use chronic pain ideas. Those injections you talked about earlier, with steroids and even regenerative medicine ideas of chronic pain have crept into oncologic pain management. Neuromodulation, the systems, both for spinal cord, dorsal ganglion, and peripheral nerve stimulation, they really took off when the systems were, you always have cases of these things being used, but really now that we can get MRIs for these patients on a more consistent basis, and that's very different for every device, the conditions, but nonetheless, because you can get MRIs are so important for the diagnosis of active disease these days, especially for metastases, that now they have neuromodulation systems that can be undergone through MRI. You're seeing the spinal cord stimulation, you're seeing peripheral nerve stimulation, and you're seeing versions of intrathecal drug delivery kind of being balanced out. Dorsal ganglion stimulation, probably for another talk. In cancer pain management, the systems aren't necessarily MRI conditional, so you'll see the use of them probably limited. The difference between a spinal cord stimulator and the dorsal ganglion stimulator is really the ability to stimulate around the focal nerve root. So if you want to stimulate the left big toe, you can put this device, the DRG stimulator, at the L5 nerve root. Whereas a spinal cord stimulator, the posterior aspect of the spinal cord, may not be able to isolate the big toe as easily. And there's some evidence of reasons for why a patient might tolerate one or the other system as a result of that. But on oncology, that doesn't exist. That's really for the chronic pain world. Our best evidence still for neuroaxial-based systems is going to be intrathecal drug delivery, using various opioids and adjuvants, and understanding the physiology of the spread of the medication within the CSF, which tends to be stagnant in nature. Understanding your actual drug delivery system, how it works, has still been is probably still the treatment of choice when applicable, when the medications are not working. The neurolytics definitely is still very common. Ideas of percutaneous chordatides are kind of coming to the United States. But neurolytics are still very common in countries that cannot afford the intrathecal drug delivery system. So around the world, for those of us listeners around the world, you'll see more forms of aggressive neurolysis and those kind of things, and because of the ability to still getting pain relief, but being a less expensive modality to deliver pain relief in that particular situation. It can be done in the United States as well, but does have a disruption of the anatomy, which people worry about. I don't know if there's any questions. I did see kind of like a hand up there, so I don't give a memo for that question. If not, we're happy to move to the second discussion journal article.
Do any of our moderators have a preference, or shall I continue and we hold off questions to the end?
Yeah, I think we can go on, and we can take that question at the end.
Perfect. So our second article is an article entitled Intrathecal Drug Delivery Systems for Cancer Pain, an analysis of a prospective multi-center product surveillance registry by Dr. Lisa Stearns et al. And I want to take just a moment for anyone who does not know, Dr. Stearns was a pioneer in the field of cancer pain. She passed away fairly recently. And although I have not had the honor and privilege of meeting her, I never had that privilege, she has impacted the life of thousands of patients and several physicians as well, some of whom are my mentors. And so indirectly, my life has been impacted by her work and her passion to care for patients with cancer pain. So just want to take a second to honor her. So we're talking about IDDS. So I have this review slide. We won't spend a whole lot of time here. Let's begin. So cancer pain has been chronically undertreated for decades at an unchanging rate. Meanwhile, the number of cancer survivors in the US continues to grow. Compared to conventional medical management, however, IDS should be considered as a possible solution. And why? That's because there are several advantages. We mentioned some, but I'll talk about some new ones. One, it facilitates systemic medication reduction or elimination. We mentioned that. And all of the associated risks that come with taking increased doses of these medications is also reduced as a result of reducing that medication. And then we'll expound on this a bit more because there are some interesting numbers I think everyone will be surprised by. I certainly was. There can be significant cost savings utilizing IDDS systems. So in the paper, it mentions that this single group cohort study presents a compilation of 14 years of observational IDDS data, respectively collected and monitored for compliance on 1,403 registry participants with cancer pain. We won't go too deep into the methods, but briefly, the guidelines that were used are the strengthening the reporting of observational studies and epidemiology checklist, otherwise known as the STROBE checklist, was not necessarily created to be a standard by which all observational studies would go by this STROBE checklist, but is becoming increasingly popular. Many people are using it, and a lot of our journals are even requiring that STROBE guidelines be used. The patients in the study were enrolled at an initial implant or at the time of a pump replacement. There were updates every 6 months according to standard of care, and up through therapy discontinuation or registry exit. And this registry that we're talking about includes patients that were implanted with a Medtronic SynchroMed 2 infusion system, enrolled in Implantable Systems Performance Registry, which is what the registry was initially called from 2003 to 2012, and those that were implanted or enrolled in 2013 when the registry was amended. The data collection, there's lots to say about it, including the various intake forms and methods of gathering data that were used. But what I really want to mention about this study is that because the registry started in 2003 and we've basically, and includes patients up through 2017, there were changes that were occurring in medicine, different ways to record baseline pain, among other things. So there were changes along the way. And briefly, looking at the patients and the demographics here, we see that there's the 1,400 patients or so, that the mean age of the patient was 59, that you had approximately 56% of females and 43% of males that were involved, and that the baseline pain score was around a 7, the median value 7. There are lots of great charts, graphs to look at in this article, but just wanted to give you some take-home points. So post-implant follow-ups declined around 12 months, but show statistical improvement in survival using IDDS. Although patients reported an increase in quality of life, from a statistical standpoint, the change in quality of life was not statistically significant. And patients demonstrated statistically significant improvement in average pain from the baseline. As far as safety goes, we won't go too deep again, but we want to look at some of these numbers that are a bit higher, involving infection with the use of the system and adverse drug reactions and pain. So discussion, and this is where we'll spend a bit more time. Opioids are the current mainstay of cancer pain treatment in the US, but they're not without potential risks, especially in the long term. This study really supports a lot of data that is already out there, showing that IDDS is safe and effective for the treatment of cancer pain. Compared with baseline in this study, patients had improved pain in a functional status at 6 months that was maintained at 12 months. And I thought this was pretty cool. This study that was published in JAMA Network in 2019, there was a retrospective claims analysis that found a savings of $15,000 at 2 months and $63,000 at 12 months compared to conventional medical management after starting IDDS. And another great thing, as I'm sure you know, with time and scientific advancement, prevailing published guidance that is continually being released continues to promote best practices and wider acceptance of intrathecal drug delivery systems. So what were the limitations of the study? Well, there was inconsistent data collection and analysis methods, which we talked a little bit about. The registry is largely limited by not having a direct comparator. Patient outcome data were mostly captured at one primary center. The registry represents a heterogeneous patient population. So even though everyone had cancer as a primary indication, there were all different types of cancer with all different types of pain etiologies, and these patients were enrolled at various stages of their disease. But a big take home and what is encouraging is that based on a study of these patients, cancer-related pain can be successfully and safely treated with medication delivery by an implantable pump directly to the spinal cord. So now we'll move on to some questions. And I'll start with the first one, I suppose. And if the moderators want to take over or however you'd like to do it, we can go that way. So Dr. Galati, what are some of the fundamental differences between caring for patients with cancer pain versus those with non-cancer related pain?
Well, we obviously, as a pain physician, we want to help all of our patients equally to our best of our abilities. So let's clarify that. What I will say with cancer pain, for non-cancer patients, their pain is their primary problem usually. For cancer patients, the pain is a secondary problem. They're either trying to fight their cancer or they're trying to get through their side effects of radiation, their actual treatment themselves, their surgery. And so they're really almost like people aren't necessarily being affected chronically by pain all the time. They're more of an acute pain problem that's becoming subacute, and then you can have some of those chronic pain overtones afterwards, and some of those changes that happen in the central nervous system. With cancer pain, it's very anatomic usually. So if a tumor is in the leg, the pain is in the leg, and you know that you can do things to that leg to help with the pain. And that's how you think about it. And the final thing is you're trying to get people through a journey of either their life or through a treatment. So there's there could be some finality to it. And then more importantly, a lot of times patients who are in cancer are not thinking about kind of their life, their family, things they haven't achieved. And so you have to kind of take that into consideration when it comes to managing both family expectations and patient expectations and trying to balance those things. So those are things you'll see with cancer patients that, trying to make it through a holiday. And so your objectives tend to be a little bit different. You're able to be a little more aggressive on certain things because you might have a time point that might make you to be more aggressive. You might not do a cordotomy in a patient that has non-cancer pain that might live for 20 years, but for the cancer patient, you might consider they might have longevity of 1 year, such that they can be with their family for that particular year. So you think a little bit differently, and you'll see variations in treatment as a result of that. So, you'll see a lot more variations on options, right? For those of you that are fellows and beyond, you go to an interventional pain physician for your back pain, the treatments tend to be similar. But for cancer patients, there might be a wide number of choices and opportunities for different ways of relieving the pain. And so you make different choices economically, access, patient, desires, and those kind of things. Let me just go to number 2 as well. Sure, why not? Okay, so the second question is intrathecal drug delivery versus SCS and DRG. So you saw a wonderful paper by a dear friend and colleague of mine, Dr. Lisa Stearns, who was very passionate about education and advocacy for the patient. And that was kind of her 2 most important contributions to the field. She specifically really focused on using intrathecal drug delivery because that was the standard of care in the early 2000s for our cancer patients. And even though we have a randomized control trial that's around 20, 25 years old now, supporting the use of intrathecal drug delivery systems, for all of these devices that you're going to see, not just for intrathecal drug delivery, at some point you have to do post-marketing analysis and see how your devices are doing in general. So with that being said, intrathecal drug delivery has a history that's about 25 years old, maybe 30 years old, for taking care of our patients with oncologic pain. Spinal cord stimulation really and DRG stimulation doesn't have that. Now the devices have gotten better, and the devices are MRI conditioned, like I said before. And so you're seeing some opportunities for the use of SCS. Our own data has been published in the Neuromodulation. And while we had improvement in pain scores, almost similar to intrathecal drug delivery, so same number of improvement in VES for relatively same number of patients, 60-70% of patients improved. The opioid use didn't. And so the difference here is the intrathecal drug delivery system is able to replace the systemic opioid, whereas the spinal cord stimulation system did always do that. And so there's some kind of characteristics of a patient that you may lend yourself to intrathecal drug delivery versus spinal cord stimulation versus dorsal ganglion stimulation and PNS. Maintaining the device for intrathecal drug delivery is a little bit more difficult than spinal cord stimulator. Intrathecal drug delivery will cover more areas of the spinal cord wherever the catheter is, whereas the spinal cord stimulator system, once you place the wires, you're kind of restricted to the location of those wires. It's not easy to change. And we have data in the literature and experience that SCS over time tends to lose some of its effect. That may be all of neuromodulation, and may not be with some of these newer waveforms. But because we don't know any of this in in oncologic patients, at many times we'll still choose intrathecal drug delivery systems as a treatment for advanced cancer pain. I will say at our institution, we've definitely introduced neuromodulation systems earlier than implanting intrathecal drug delivery system. And so even in our system, we're seeing variations of how we practice based on access and what we think will be helpful. And so I don't think the algorithm is quite set. I think you're going to see diversity in how the algorithms are run in various institutions around the world. We tend to be a little more aggressive with neuromodulation because we are trying to prevent the side effects from the chemicals or medicines that are in the intrathecal drug delivery system. Bupivacaine, which is a local anesthetic, can make you numb. And so to avoid that, spinal cord stimulator systems will not necessarily prevent your motor axons from firing. And so those kind of things. So there's some variations of why you would use one or the other, probably beyond the discussion we have right now. But you'll see some of this stuff being electrical analgesia being introduced to oncology. Some of it started in oncology actually. So because at that time, the severe pain was patients suffering from cancer. So we really applied some of these devices that are in oncology first and kind of went back to taking care of chronic pain patients and vice versa. What will make this more interesting is as these devices get better, you'll see more diversity of applications. Number 3, in general, what are the main factors you feel contribute to patient successes with positive outcomes? Physical therapy, home exercise program, regular check-ins, dose measuring, and programming. So, this is you should do all of these things if you can for all of your patients. Sometimes access to physical therapy and an appropriate home exercise program is challenging. So some of those, if you have kind of expertise in this, you might offer this to your patients directly as opposed to reliant on therapists that may not know how to take care of a certain population of patients. So, pre-rehabilitation and rehabilitation before mastectomy for breast cancer surgery has been shown to be very helpful. If you can do these things, keep patients active, keep up their nutrition, and I'm speaking specifically for oncologic patients, you probably have a better chance of taking care of them. They have a better chance of being with their family. They probably have a better outlook in fighting their cancer. Whether that translates to actual improvement in cancer longevity, probably much harder to prove because our cancer treatments are so much better than they used to be and they keep evolving faster. But I think patients are very responsive to regular check-ins, even a talk on the telemedicine phone once a month. A lot of times it's a lonely disease to treat. You're many times going into a facility every 2 weeks, every 3 weeks, getting an infusion of a chemotherapeutic agent for a few hours, an hour. You're feeling sick from that. You're going home and repeating the cycle. It's very hard to maintain a normal life while you're getting oncologic treatments. Sometimes radiation requires multiple weeks of treatments on a day-to-day basis. And so patients, more than anything else, just want someone to talk to, someone to help them through the process, understand the process, and these ideas of dosing medications and regular check-ins are always helpful. We feel that as a cancer pain physician, it's almost something you should consider doing. It can be more of a practice burden, but it's rewarding to help your patients because they tend to be needing your care, and they tend to be more thankful that you're helping. But that's by far just experience that I have. That's not a global discussion of patients that are cancer versus not cancer. But all the things that are listed are helpful. Probably the best thing you can do is understand the path that an oncology patient is going through, understand what radiation would do, understanding what chemotherapies will do. Many times I'm attuned to what the patients are going to go through, and so I can describe to them the pain parts of these things. And just the fact that you can alleviate some of these fears and expectations goes a long way in helping a patient.
Thank you, Dr. Galati, and thank you to both the presenters. We do have a few questions from the audience. The first question is from Brian, so we'll go ahead and answer it live. Is there any way to prevent the conversion of acute cancer pain from becoming chronic cancer pain?
I mean, you could cure the cancer. There's no real one way to do it. Look, I think when it comes to some of these ideas in chronic pain management, where acute surgical pain becomes chronic in nature, phantom limb pain, there have been a lot of attempts to change some of the, using different to change the trajectory of these things. People have tried. Gabapentin was a big one when I was a fellow, trying to use gabapentin to prevent these kind of the conversion of acute to chronic pain. In oncology, usually the pain is caused from a physiologic problem. Chemotherapy is actually just destroying the ability for nerves to regenerate appropriately in some way, stopping mitotic function. And so a lot of the cancer pain issues are because of treatments or cancer growth. So it's chronic because of time points. It may not be chronic because of changes in the central nervous system. I will say a lot of those things have not been studied in the cancer population. So we're not looking for changes in fMRI, a certain location of the brain based on the pain being there for 7 months, 10 months. It is possible those things are happening. But that really hasn't been shown in oncology pain management. So best thing to do is to treat them early on so you can minimize the risk of side effects of chronic treatments of pain. So in other words, if you're using opioids, you're trying to, instead of escalation, maybe rotation, try non-adjuvants, try the interventions that we have available to you earlier. So you're always managing the pain and not reliant on medications that may lead to significant side effects. And on the flip side is some of these interventions have side effects. So you want to be judicious on their uses because our patients in the end are trying to fight the cancer and they're not necessarily trying to look for another side effect of a treatment we're trying to offer. So we're aggressive in helping patients with pain, but we're judicious on the right things to do and balancing the positive, negatives of risk or benefits of each patient and their intervention.
Another question that Brian had was, what role do you see using modalities like low intensity focused ultrasound and acupuncture with cancer pain?
So I'll give a little story. When I was in a medical school, I was at Baylor College of Medicine. And when I wanted to go into pain management, one of my residents told me, before you go into the field, go to majors. Back then, when we went to major bookstores, went to bookstores, which are a little different now. So we went to majors bookstore, and I went to the medical section and looked at all the different disciplines. And I liked wilderness emergency medicine. And I found a book on alternative treatments for pain management, which I didn't actually think about. So that book was talking about acupuncture, Reiki therapy, craniosacral therapies. LifeU actually wasn't on there at that time. But the point is that in pain management, we have all sorts of different disciplines that are helping our patients. And oncology pain management, acupuncture has probably been more studied than any pain therapy that I can offer. So if acupuncture for hormone replacement therapy when women have treatments that are going to be prolonged to prevent the recurrence of cancer in their breast, acupuncture has significantly more randomized control trials than anything we have in oncology, and probably even most of pain management, if you believe that, would be my guess, educated guess. So yeah, people look for treatments that aren't invasive, that they can do fairly quickly, that can be effective. So you can see treatments like ultrasound, TENS units, acupuncture being applied and with success. Patients tend to want these kind of things. If you were in the same boat, and as much as we want to implant a spinal cord stimulator system in the spine, if you're a patient and you knew that you could do acupuncture that would help similarly, most people, I think, would choose acupuncture. And so as a physician and as a cancer pain physician, you want to at least be aware of these modalities. If you're not going to deliver them yourself, who can you send your patients to? The idea of a great narrative review like you read earlier in the first journal is that you learn all the different treatments that are possible for a cancer pain patient. And then you want patients to at least be able to access it. If you can't deliver it, who in the community can offer those procedures to help a patient? And similarly, an acupuncturist, similarly, someone who's doing non-invasive neuromodulation therapies like a TENS unit, scrambler therapy, all focus ultrasound, a low intensity focus ultrasound, lasers, these kind of things can be helpful for all sorts of different pain states. That really does include a lot of oncology patients. So I think it's a part of your paradigm. It's part of the earlier part of your algorithms many times. And you work with a patient about what kind of access they have and you have to these modalities where you eventually will practice.
Dr. Gulai, I have one question for you. So we want to inspire the next generation of doctors going into cancer pain. So
Me too.
tell us, what do you love about treating cancer pain? What makes it fun for you?
I don't like the word fun. I mean, I enjoy treating our patients, and then a real goal is to really help patients who I think are suffering. For me, early on, I was at Emory University for my residency. I worked with Dr. Michael Bias-Smith, who's passionate about helping his patients. Back then, he would make house calls. He puts an epidural and those kind of things if he had to, and late at night to help a patient in the emergency room. He really cared about those patients because they were suffering, and they're suffering, and they don't have, their outlook may not be necessarily the same as ours. Where when thinking about living till our very older age, they may be thinking for the next 6 months. So at that time, I felt that of the patients I could help, that was the patient population I think needed help. And I just had the opportunity to kind of continue my career at New York City at Memorial Sloan Kettering, introduce some of these concepts from regional anesthesia, also on guidance, for example, for a lot of these blocks. Take some of the ideas from chronic pain medicine, interventional pain medicine, and apply them to our cancer pain patients, and give a diversity of options for our patients. I think what makes it fun is that the options continue to improve in terms of all pain management, and that we find clever ways to apply that to our patient population. And more importantly, oncology, their treatments are changing dramatically. The longevity of a patient is changing. So you're changing your treatments because the outlook is changing. So the things I might have done neurolysis wise 5, 7, 10 years ago, I'm not offering. I might instead of putting a peripheral nerve stimulator first before I destroy an intercostal nerve. I would not have done that 12 years ago, but the patients were only thinking about 6 months. Now I'm thinking 6 years. Do I really want to destroy a nerve 5 times, 6 times, and not knowing how it's going to come back? So things have changed, and the fun part is seeing the innovations come in and how to apply the innovations, because other specialties are innovating in cancer as well. That's where the fun and the passion is. I think it's less routine than perhaps some of the other aspects of medicine and maybe pain medicine as well. And so that's kind of where I lie on the spectrum of pain treatments.
Awesome. We'll give the audience maybe another minute. If anyone has any questions, they would like to type in the chat, or you can click the raise hand button. I see another one. Okay, so there's a question by Mohammed Hakim. All right, so thanks for this great presentation and insight. What has been your experience on cannabinoids for cancer pain as part of the multimodal ladder of medical management? Also, how about musical therapy for cancer pain or anxiety?
Yeah, so the first one, cannabinoids, that's been used in oncology for many years, probably a few decades. My personal experience has been I'll use access to CBD first because it seems to be easier to obtain in New York State, and then versions of the THC and CBD. I will say I don't have as much experience with their different ratios and those kind of things. Those things are sometimes not easy for a physician to control in our state, at least. But by and large, I think the patients who tell me that's effective tends to have an anxiety type component to their pain. I don't find it a universal panacea for pain management in cancer patients. I'm very liberal about trying the medication, but I find that many patients don't find it as effective. I'm not sure. Anecdotally, I tell people it's about a third of the choice, but honestly, I don't know the actual data. But I haven't found it to be universally helpful when it comes to true pain management of a cancer patient. I will say it's very helpful when it comes to anxiety, the appetite stimulation, the relaxation. I think that's been much more of a improvement. A lot of patients can't tolerate the cannabinoid itself. So I treat it as another medication option. I really don't think it's the first line, second line, third line. It's one of the lines that you can try. And I'm open to our patients trying it. Sometimes, and depending on where everyone's living, we have different accessibility to the different versions of the marijuana derivatives. And so you have to kind of navigate that. Second question about music therapy, cancer pain anxiety, music, art therapy, dog therapy, all these different versions of therapy are offered at Memorial Sloan Kettering Cancer Center. They definitely have a component of being very helpful. I know colleagues of mine that'll put on music while they're getting the intervention. They have an injection, for example. And so if you appropriate music therapy and a music song for a patient, you can definitely have a change in their mental state. That can be very positive. Maybe you put on Stravinsky, it'll be negative for all I know. But there is definitely evidence for this, all these various forms of therapy. I will say the kind of the novel thing that's happening in the field is the use of virtual reality to achieve some forms of anxiety relief. One of the things when it comes to this field is really understanding what other fields do. So when you talk about hypnotic suggestions and hypnosis, many people probably don't read about the true hypnotic stages and how to achieve hypnosis. And the same thing that happens for virtual reality is you're not just working on one sense. Music therapy is working on your hearing, for example. Art's working on your vision. Dog is working on your touch. But in the dog therapy actually has some sort of vision and put a sight associated with it. There's some other senses, but VR is focusing on sight and hearing. The more senses you can involve or invoke, either hypnotically or physically, the better off you're having a change in a mental state. And so that's what the basis of hypnosis is. The guided imagery will involve a beach, but you feel the sand, you'll feel the warmth of the sand, you'll feel the coolness of the water, you'll hear the waves crashing into your feet, you'll see the sunrise coming through with the little the colors of pink. You're invoking all the different senses. And so all these therapies you're talking about, that's what you're trying to do to reduce anxiety, to induce a change in the mental state. And it's actually very fascinating if you ever want to read anything. I don't read that many pain books anymore. I tend to read this kind of stuff because there's a lot more ways of managing pain and associated mental kind of health issues associated with pain management that you can really add to your practice as you get further and further along.
All right, if we don't have any more questions, we'll go ahead and conclude the webinar. So thank you again, Dr. Gulati, for being here tonight and offering your expertise. And thank you, Edward and Pankti, for presenting tonight. If you are a NANS member would like to join, go to neuromodulation.org. And if any of you are interested in being part of the next Medical Student Journal Club, we have a sign-up form. I know the link's kind of long. You can feel free to email us at info.nansrfs@gmail.com. We will also be tweeting out the sign-up form on occasion, and we'll be informing y'all of our next journal club. So thank you all for attending tonight.
All right, bye everyone.
Thank you, everyone.
Thanks, everyone.
Thank you.